Hello and welcome to the Next Complete Physio podcast. My name's Chris Myers and I'm here talking with Mr. James Calder today, who is a very well-known foot and ankle surgeon. So James, thanks very much for joining us. Today we're going to be talking about ankle sprains, and obviously lots and lots of people sprain their ankle, but we're going to talk about it from a surgical point of view and whether or not people that have bad ankle sprains should actually be looking to have surgery. So James, first question is, well, how many ankle sprains do you see a year? And particularly, what is the subgroup of people that you think maybe should consider surgery, and at what point in the injury?
The numbers, I don't know how many I see, but every week. My practice is mainly elite athletes now, so it's a very different practice, but we'll see several each week. But not many of them will need surgical intervention. I think that's the biggest take-home message. There are thousands every day, one of the commonest injuries to go through A&E. So, and the vast majority don't need an operation. I think we need to separate perhaps the difference between the normal ankle sprain and the normal individual, and the expectations of an elite athlete.
Okay.
And there's perhaps a grey scale in between, but for the elite athlete, we have moved towards surgical repair in a select group. But still, the vast majority will not need surgery.
And how long has this been? Because this is obviously a slightly newer thought process that surgeons have been having, and I'm sure that's driven by data. But how long have you been, for example, doing this sort of repair?
Well, I disagreed with doing a repair 10, 15 years ago, because I said that they get better. If you look at the data, they get better with conservative management and good physiotherapy and a short period of immobilization. But certainly on the continent, surgeons were saying, actually, there is a subgroup where they may require surgery. So once again, I was wrong and they were right. And we looked at the data, and we had a meeting, an ESCA meeting and an ankle instability group meeting in about 2013 in Warsaw, and then again in Prague, where we actually looked at the data, went through all the different papers and said there probably is a group who may benefit from surgical repair.
And what was the data showing you for you to think that? Was it the fact that they were still getting pain after, or re-injury, or had problems 20 years down the line?
Well, the UEFA studies came out with showing that there is a significant risk of re-injury if you get a bad ankle sprain. So it's when you get a rupture of both the ATFL and the CFL. And if they have gross instability clinically, when you examine them 5 or 10 days later, because examining them immediately is fine on the pitch side and it'd be grossly unstable, but then the swelling occurs and really you can't get your hands on them for about 5 or 10 days. And if there's gross instability at 5 or 10 days, then that group may benefit from surgery, because there may be a 20% re-injury rate in the same ankle in the same season and a 30% re-injury rate over the next 3 years. So that's for a professional athlete, that's a problem, because it may take 6, 7, 8, 10 weeks to get back to playing. And then if they have another timeout, then that's another 2 months or so not playing. It's expensive if you look at it from a commercial point of view for the club. But for the player, especially when they're youngsters, there's that aspect they take that time out. The next thing is, what about the problems that can ensue if you have subtle instability? So the ankle may give way several times, but you may not have to have 3 or 4 weeks off. But we all see the footballer's ankle with the osteophytes and the osteochondral lesions. And if you have an osteochondral lesion with ankle instability, that generally speaking is bad news. You do need to stabilize the ankle as well as treating the osteochondral lesion. And you can get perineal problems and ongoing things like that. So what we're trying to do is prevent the longer term problems.
So let's just define the group, because as you say, there'll be lots of people that do an ATFL injury, whether it's high grade 2 or a grade 3. So if it's just an isolated one ligament, would you still consider this, or would it be for as you said, multi ligaments? So maybe the CFL, I suppose AITFL is a different ball game, but how would you look at it?
It's interesting. It probably comes back to anatomy. So we've done some work both here and in Barcelona jointly with Mickey Dalmapasta, who's the anatomist in Barcelona, and we've brought the specimens into the UK as well. And at Imperial College, we've done the dynamic robotics looking at it. And we now know that the ATFL and CFL are not separate. there are two bands of ATFL, and they're joined together with a CFL. So if you get this,
as in through the, because I've got my ultrasound hat on. So obviously a ligament is a thickening of the capsule.
Yeah.
So do you mean it's joined via the capsular element, or they are joined at the fibula?
Well, the ATFL has.
We're going to get
look
technical
at
now,
a paper. It's published in Kister Journal,
Yeah.
and it's a great anatomical paper by Mickey. And there's an intra-articular and extra-articular components, fascicles of the ATFL, and they're joined together. So if you get a sleeve avulsion of the ATFL and the CFL coming off, those are the ones that probably have very significant instability. The other group that may have instability is when in these slightly less common ones, when the ATFL has been avulsed from the talar aspect, the talar footprint. And those are the ones we see, actually, they can be quite lax. But what it also means is the surgery's changed, in that Jon Carlson from Sweden, when he wrote his thesis in the last century, he talked about, we only need to do the ATFL repair in athletes. But he didn't explain quite why. And that's because we didn't know the anatomy then. And actually, if you repair the ATFL, you're often bringing up the CFL as well and repairing it as well at the same time.
Right. Okay.
So that's why the sort of the modified Brostrom repair works so well. So getting back to what you want to know is, we think that if you have an ATFL and CFL injury, it's worth examining, see if there's gross instability in the elite athlete. They can be treated conservatively and they can get better, but there's a risk of having a recurrent instability.
Do you think it's the CFIT? So it's the CFL element, because obviously that goes across the two joints, doesn't it? So
so I think it's when you get them both off. That's when they go.
Avulsed.
They get avulsed off.
Not a mid-substance.
They can sometimes have a mid-substance,
but it's less common.
Often the ones that I see, they seem to come off from the origin, and it may just be distal to the fibula. And this isolated ATFL, by and large, they can be treated conservatively by and large, this isolated ATFL, unless, once again, there's gross instability, or they've had recurrent sprains and they've got some chronic instability on the background of that. Yeah,
because it could be their second sprain, couldn't it? So you might look at that as a slightly different subgroup as well from the recurrent injury.
And I do not think that we need to go and repair everyone's lateral ligaments. I mean, we can't. It's one of the commonest injuries coming to A&E. So we don't need to go down that route. But we know that the repair is good. We've just published 147 elite athletes in the American Journal.
When you say elite, James, are we talking
professionals?
So they make a living out of sport. So it could be League 2, League 3 football, or
yes. We've actually only taken Premier League and European Championship League and Championship level football. For football, and then we've taken Olympic sports such as hockey and Premiership rugby as well. So those are the groups.
It's a great data set, though.
It is, but
very uncommon in elite sports get that data set.
Yeah, but the reason we took it is not so much the operative aspect. It's we know that they've had perhaps the best physiotherapy. So it's been consistent. Whereas if we take all comers, they may not be able to get access to physiotherapy at that level. And that's going to be key.
Because what you don't want to do is do surgery and then, they don't get their physio for a few weeks, or they only go once every, that's not ideal, is it?
Exactly. And then also we need to know, are we delaying their recovery? Whereas the results have suggested we get them back in about 9 weeks, which is quicker than I'd anticipated. I was always, a few years ago, talking about it taking 10 or 11 weeks, maybe 12 weeks. But actually, on average, it's about 9 weeks back, which is pretty similar to if you treat these big lateral ligament injuries conservatively.
It can take longer than that, can't it? Because I was going to ask you that, is that, if you turn around to a club and say, well, this is the injury, I think or an option, because obviously it's something you're going to discuss with everybody, but an option is surgery. One of the concerns, if I was the chairman paying the bill, is, well, does this mean they're going to be out for a lot longer? But what you're saying is it doesn't seem to be too much difference between surgical and conservative.
No, it doesn't. And I think that what it does is it gives you more security and more surety of getting back and it seems to reduce the risk of your recurrence. And we've had very few recurrences in that group of 147, unless they've had a big injury again. So,
and it's fundamentally, we all know, if you sprain your ankle once, you're way more likely to sprain it again, aren't you? And that's obviously being conservatively treated. I'm sure the general public don't all have physio after and that sort of thing. there's no doubt it's like an ACL. If you don't have an ACL and it keeps giving way, you're damaging your joint, aren't you?
Yeah.
So is there a similarity, I suppose, to...
There is, and I think we need to be careful about how we manage them. So still a period of immobilization is the best key. And then functional rehabilitation, getting them strong.
Yeah.
But not, I prefer people not to use ankle braces all the time, because they've got to get their own inherent strength back. Because an ankle brace won't hold them all the time when they're getting back to tennis and multidirectional sports. So if they're still getting instability at that stage, that's the time when you probably want to say, well, you may be wise to consider an operation. But a short period of immobilization is definitely the way forwards. Probably 2 weeks, it still seems, the Sarah Lamb's paper suggests that years ago. It wasn't a particularly good paper, but with the follow-up and things like this. But it seems
we still
reasonable.
use it. We 2 weeks, we throw that. I threw it out this morning, actually, with a patient.
Exactly. But I think if you're going to treat a CFL, ATFL with a bit of more instability in the normal, non-professional athlete, I treat them a bit longer in a boot. And I will leave them in a boot for about 4 weeks. Now, there isn't much evidence for that, but we know that ligaments will not heal in just 2 weeks.
And how many do we see that go a bit early and maybe get a bit of a synovitis because they've gone a bit early, and it can be really difficult?
During that time, you can still do physio. So you can still get dorsiflexion back.
Yeah.
But the thing you want to avoid is the plantar flexion and the hindfoot inversion, and just rest the ankle a bit and get it to heal up.
And you can do an awful lot without stressing it like that. And so let's go back. So you see a patient, you're thinking, well, maybe this patient does need surgery. I assume you're making that decision obviously through an MRI scan. And your clinical assessment. Can you just talk us through your thought process on both of those two things in terms of that subgroup that may require surgical intervention?
Yep. So the history, first of all, what was the mechanism? Next, with the examination, looking at it, hopefully, like I said, seeing it 2 days after the injury is often not helpful. So I tend to, even with elite athletes, I'd tend to say, please, can you leave it 5 to 7 days or 10 days?
Yeah.
So get the swelling down, get them in the game ready, get it all under control. And then the clinical examination, yes, is it isolated to the lateral ligaments? If they've had severe injury and there's an injury to the medial deltoid, that's a different kettle of fish, because then you've got multi-directional problems.
Yeah.
And in those situations, if you've got an anterior part of the deltoid, so the navicular tibio-spring ligament has been avulsed, that's a very difficult problem to manage conservatively.
That's a different group, isn't it, that we're talking about?
But it's important to get that before you can send them for the MRI scan.
Yeah.
And then examination to see whether it's concomitant syndesmosis injury, because those are the other ones where actually pushing them on and too quickly with physiotherapy, that actually just leads then to a bit of subtle instability to the syndesmosis, and it's quite a difficult problem, and you start getting the synovitis. And also the patient needs to know that it's going to take a lot longer than, it's not a 6-week injury. This is exactly, the gloves are off at this point, and they will need a period of immobilization that's longer than your 2 or 3 weeks.
Yeah, absolutely. So from a surgical point of view, so I'm not a surgeon, but roughly what do you do in the surgery if there is a ligament repair that you want to
my take on it is that we do an anatomical repair. Right. All the evidence would suggest that we should do an anatomical repair. And in fact, there's a paper published from Harvard last year, systematic review with Chris Giovanni's group, and they suggested anatomical repair is the best way forward. I do a modified Brostrom, which is the classic way of doing it. It's got very good data. It's anatomical.
One of the most successful operations
probably
done across the world, the rostrum.
It is. Yeah. I do it through an open technique for the vast majority, certainly in the with a mini incision rather than arthroscopic. It
just
can
for
be
visualization.
Yeah, because I want to make sure I've got the ATFL back into the footprint. Yeah. And I know that by looking at it through an incision, which is a centimetre and a half in length, if I do it arthroscopically, I've got 3 portals which add up to about a centimetre and a half in length.
Yeah.
So and I can see it, visualize it there. So I don't have a problem doing it open. It doesn't seem to have any greater risk. But it's an anatomical repair. Yeah. I don't usually augment it with other fibre tapes that can be put in to augment it, because I prefer to have as little foreign material as you possibly can in there. There are times when we use a fibre tape augmentation. It's usually in the more chronic cases,
like an internal brace.
There is an indication. There are indications rather than there is. There are indications for it. Really, in the revision cases, those when there's been an avulsed fragment, which you have to take out, so there's a gap, and those that have got really quite generalised joint laxities with Baden scale of more than 6, something like this.
Sure,
those ones may have a recurrence.
And that's another interesting subgroup if you've got a background of hypermobility as well, which always makes things a little bit trickier, doesn't it?
Yeah.
In terms of just slightly going off on a tangent, what age? We talked briefly before the podcast. Is this something you would consider in an adolescent, or is this really just for your more adult population?
It's less common in adolescents. I think probably with my practice, I see 17, 18-year-olds fairly frequently from the professional football side, particularly, and perhaps a little from the rugby. Yeah. But so I have a slightly skewed
of
picture
course,
on this. But the number of ankle sprains are out there. I wouldn't advocate going out and repairing them in a lot of adolescents. I think if there's gross instability, then we need to take a view on it, because you don't want them having cartilage problems later on. And
when's the optimal time for surgery? You want to assess it around 5 to 7 days, you're seeing, because when the swelling's gone down. But where is there an optimal time? I'm assuming quite quickly. But
for the elite athletes, we would get them in within a couple of weeks, certainly. And if the swelling's down after 5 days, we'll do it straight away as soon as there's a slot available, and as soon as the swelling's gone down, and as soon as that decision has been made, they'll want to get back, because every day counts to get them back to a Premier League match and stuff.
Getting back to their job.
Yeah, exactly.
So you've done the operation. Are they in a boot? Tell us a little bit about the rehab, if you like, afterwards.
First 2 weeks, I tend to leave them more in a back slab, just to rest the wound, get that healed.
I've been in neutral.
In neutral, so up in dorsiflexion. And I'll leave them without weight bearing, just because I want the wound management, the foot up in the air, get the wound healed.
Yeah.
We've been pulling that back a little bit so they can come out of the back slab at about a week, so they can get physiotherapy.
So they're at that point in a back slab, non-weight bearing with crutches.
Yeah. And then I'm happy at a week to 2 weeks, somewhere along the line there, that they start physiotherapy, because I want to get that dorsiflexion back. I want them to push the dorsiflexion. Absolutely.
Yeah.
And then the stitches come out at 2 weeks. They're in a boot from 1 week or 2 weeks, depending on where they are in the country and how well I know the physiotherapy team that's looking after them. And then they start the rehab. And avoidance of plantar flexion inversion until 6 weeks post-operatively. They start perineal strengthening from 3 to 4 weeks post-operatively. That's not a problem. But really, I want hands-on, game ready. I want the calf complex. They can start using BFR, blood flow restriction therapy as well. But I really want to get the range back. So I ask that they aim to have the range back by 4 weeks post-op.
4 weeks. And then the next 2 weeks would be getting ready to return to sport, I assume, going through that.
Yeah, so they can come out of the boot at 4 weeks, 6 weeks, depending upon what we found at the time of surgery as well. But I'm usually happy for them to come out of the boot at about 4 weeks post-op, maybe use an A60 brace for a bit of support for another 2 to 3 weeks, just to stop them rolling it when they're out on the pavement and outside, away from the club. But they've got to really push on with the physiotherapy, and they can start. They usually start on the Alter G and build up in the Alter G at about 5 weeks and build up through, which then aim to get them back on the pitch for return to play at 9 weeks.
Right, yeah. That's pretty good, isn't it?
It's
and
quick.
I assume you're following these guys in your data set.
Yeah.
What's the longest, how far through that are you at the moment with follow-up?
We've got 17 years of follow-up now.
Oh, wow.
So, but not vast numbers, because I wasn't doing
of course.
very selective 17 years ago. But we've got very good follow-up for the last 10 years with quite large numbers. And like I said, we've got 147 we put in the elite group with greater than 2 year follow-up. Yeah. So,
and looking positive so far with recurrence of injuries.
Yeah, it is actually. And I think, but the good news is it's not just me. I'm always fairly cynical about, one person's view is.
Yeah, sure.
Whereas this is being reproduced in other series as well. So it's being reproduced in the Middle East, in the US as well, and in Australia. So there are different groups that have been doing this as well. So it's not all just.
I mean, how many times do we see in clinic people they say, "Oh, I've got a weak ankle," and you're like, "Well, what do you mean by that?" "Oh, I sprained it when I was 16, and every now and then I sprain it again." And you see an awful. If you can change that through potentially early intervention surgery, obviously not advocating surgery for everybody, but for that subgroup, that can make a huge difference. And the other thing, James, is so many people end up getting osteochondral defects, arthritis, and other problems around the ankle because of that, if you like, micro instability, or what is not actually even micro instability. They literally are rolling their ankle.
Well, it's very interesting. You bring up micro instability. Now, once again, Calder was never a great believer in micro instability.
Right,
And I think, once again, Calder's probably wrong.
Yeah.
And I think there is an element of this. I'm not sure we need to call it micro instability, but there is an element where, particularly if you look at the fascicles, if you just break one of the fascicles, which is intra-articular, so therefore it's like the ACL, it will not heal because the joint.
So it's under the capsule.
Yeah, so it's within the joint, it's intra-articular, so therefore it gets bathed in articular fluid, and it will not heal. Now we're seeing that on the MRI scans. So Jay Lee and Adam Mitchell, who work
can you guys
here,
see it on ultrasound?
So, well, they can see it on MRI. So we've got a paper that Jay Lee and Adam Mitchell have just done with me and one of my research fellows, and showing that you can identify these different fascicles and ligaments. And those are the ones that they seem to have not a regular giving way. They don't fall over all the time, changing direction, but they have a feeling that it's not quite right, and they get recurrent pain, and they get some impingement pain, and they then have this subtle instability. And if they've got an osteochondral lesion, that deteriorates because it's subtly unstable. Yeah. And if they've got perineal problems, so a perineal split, they start getting tenosynovitis around the back because the perineals are then having to compensate.
Yeah. So, and when we talk about we're essentially talking about laxity, aren't we?
Yeah.
Yeah. So instability being the patient will say, I feel like I'm going to fall over, but there's clearly going to be movement as a result of the deficit in the ligaments. And you're saying the studies that you've done at Imperial, that's where this is coming from, I assume.
Yeah. So there's something there. Jordi Vega, who's a surgeon in Barcelona, and he's been talking about this for years. And I've been arguing against him, saying, I think you're overcalling this. And
what's
things.
He talking about?
Exactly. And we meet at many meetings around the world. And I think he does have a point, and I think there is a point with this. And there is an element where an arthroscopic repair may be indicated in those individuals.
Yeah.
Because you can tighten that up, you can put that fascicle back on, and you can tighten it up, and it doesn't need a big open repair.
Yeah.
And he's got some good results with that. There's another chap in Bordeaux, Stefan Guillot, and there's a new group or another group from Singapore, and they've been talking about it as well. So I think there was a general move that there may be a place for that.
And what often happens is things start in elite sport, don't they? Yeah. And you get some good data sets, and then it does have that trickle-down effect, doesn't it? Where your weekend warriors, you're now starting to think, well, actually, maybe we should be managing more like that if we can prove that the outcomes are good and that there is less recurrency long-term, which is actually what a lot of patients care about. Yeah. Like, you're going to heal, and the next question is, well, is it going to cause me problems long-term? Well, actually, the data on ligament sprain says, yes, it probably will.
Yeah, and I think that's philosophically, that's the great thing about what we deal with elite sports. People, say, what's the point? It's not transferable. It really is.
Things start there.
Because we can do we've got a very controlled group of people who've got a very defined injury. We've done a very defined surgical procedure on them. But then we've controlled the physiotherapy and the rehabilitation. So we know how it could be if we get everything, the ducks all lined up.
Yeah.
We can then take that and then reproduce that in normal individuals, hopefully in the NHS and the wider NHS as well. I get that rehabilitation is difficult, but some of that can be online, but we know that we can pick up these injuries earlier. And ultimately, we've got to be able to prevent the arthritis, the longer term problems in these individuals
which then actually become a burden to the NHS as well.
Absolutely. It keeps they become a burden to the NHS. They're not working, so they're not paying as many tax, tax, and it goes on and on and on.
Yeah.
So if we can pick up these things earlier and probably encourage the physiotherapy and the rehabilitation earlier, then they can prevent the longer.
But I suppose that the risk with that trickle down effect from elite sport is, you've said you've controlled it, and actually the weekend warrior who's going to work, who can't take time off, who sees the physio once, that's not actually the same group, isn't it? So you can do a great bit of surgery, but actually what your results show is that, well, what we know at this stage is that the surgery works, but you've got to then have the physio, you've got to have the communication with the surgeon. And if you don't have any of those elements, it might not show such a good outcome. So then you start doing it on people that don't have that, and the outcomes can become
absolutely. And I think that's why I think that I was saying earlier, I think there's a danger of everybody going down the route of having surgery, because we create all sorts of problems. A good operation can be ruined by no physiotherapy, no rehabilitation, with all the best intentions, and we need to be very careful. So yes, I think there probably is an indication for the very type A personality, weekend warrior who wants to get back to playing what he or she may consider elite level sport, but not at the elite level, not with an elite club. But they've got to be able to put in the hours that's taken for the rehabilitation. But there probably is a group where and I do still see some patients coming through who I say, actually, I think that person would do better by having surgery because they've got gross instability. And you kind of look at it and you kind of go, I can't prove this for you, but it just doesn't look good having a
It's quite similar to dislocations of the shoulder, really, isn't it? As in, well, I don't know, see what you think of this, but if we know that, don't quote me on this, nobody quote me on this, but under 21s, you know, if you're a first-time dislocator, we know you're very, very likely to redislocate at some point. And we also know surgery is very effective. Do you think there's an age element to the answer in terms of who you repair?
I don't know about age. I think it's what the expectations of their level of activity probably denotes it. And that's probably, I see a much younger age group because of the nature of my practice.
A majority in their 20s, which we're talking about.
Because
that's important actually to know.
So I think, that's the majority of my patients are younger. So I'm not seeing the 60-year-olds. But I don't think even 5 or 10 years ago, I was seeing many patients in their 60s who'd got chronic ankle instability.
Well,
they were getting arthritis.
They're normally bad by then, aren't they?
So
you're looking at other options.
Precisely. Yeah. So I think that it's a younger person's problem.
Yeah.
I don't know about the adolescents as to whether we haven't got the data to support whether that's.
It'd be interesting though, wouldn't it?
It would be. I mean, we do know that the paper from the BJSM from 2003 showed 20% recurrence within the same season with big ATFL, CFL injuries in football in UEFA, and other studies suggested 30% within the next 2 years. So it is a problem in the adolescents.
I often quote, I don't know where I got it from, but 30% at 3 months after an ankle sprain still have problems.
Oh yeah, I mean there's the pain problems and there's the failure to progress, and I think we've missed. We certainly in rugby, where a few years ago you couldn't get an MRI scan as easily because and there still isn't the money in rugby as there is in football. Yeah. But 10 years ago they were not doing as many MRI scans. We looked at the numbers of patients who got an ankle injury, and some of them weren't getting better. And John Brooks, who was a professional rugby player, a prop with Harlequins, is now a doctor. When he retired, he's now a doctor working in Australia. And he looked at there's a bimodal distribution, and they got better. But then there was this other group that didn't get better for 6 months. And in fact, when you went back to them, they'd actually got a syndesmosis injury, and it hadn't been picked up, hadn't been recognised. Yeah. Which is why I was saying to you, it's really important to clinical examination. If there's pain medially and there's a deltoid, and you prod up the syndesmosis, and you think there's a syndesmosis, then
there's a different pathway, basically, isn't it, to what we're talking about?
But there's I talk about it being the tip of the iceberg. Yeah. So if you get that little beak and you go, hold on a minute, let's look what's going underneath this. And that's another study that both Adam and Jay did, was looking at the MRI scans and looking for this, what we call the ring of fire. So as in Johnny Cash song. Okay, yeah. The ring of fire, where you get bleeding around the circumferential bleeding around the tibia from it, and it suggests there's a syndesmosis injury. So it's not just a simple ankle sprain. And if you pick that up on an MRI scan, think there could be a syndesmosis.
Bit of a red flag.
The Bruce Reader, who's the American Journal of Sports Medicine editor, didn't like. He said, "No, we can't use a ring of fire because it's a song." And I went, "That's the point."
Yes, people will remember it.
Exactly. And eventually they allowed us to put it in.
Last question, James. The idea of early, and I know you're a foot and ankle surgeon, but I know you've got particularly, at Fortius, you've got loads of different surgeons all doing lots of good research. Do you think the principles of what you're learning with the ATFL are gonna start being extrapolated into other joints? I'm thinking of an MCL of the knee. I know you're not a knee surgeon, so that's a little bit unfair.
It's interesting. I think there are changes, though, aren't there?
I think so,
within different areas. So the the old Macintosh repair was talked about years ago, and pretty much I think every ACL gets a modified edition of a Macintosh.
Yeah, they do seem to.
And I think people are looking to this a lot more, and the meniscal root repairs. Because there's a subtle instability. Within the knee. It's well out of my area of expertise. But I think we are looking at the anatomy. At the end of the day, it comes down to it. In that there are some. There's a chap called Pau Galano, who was the most amazing anatomist in Barcelona and a good friend. And he unfortunately died aged 47, 48 of a brain hemorrhage. And his protege was a very young guy called Mickey Dalma Pastor. And he had to step up, and now he's the professor of anatomy in 10 years later, 8 years later in Barcelona. And he's doing the most fantastic work. And it all comes down to anatomy. And whether it's at the hip, the shoulder, we're doing a lot around the ankle at the moment, because you realise once we can understand the difference, rather than having the old dissections where the ATFL was one band going this way and the CFL was one band going the other way. Hold on a minute, it's a little bit more complicated than that. But once we've got that understood,
I think part of the problem is when you see, you do a pro section or something like that, and I've done a little bit myself recently, and you realise that we've learned anatomy for us to be able to learn it. There's 3 bands of this, there's 4 bands of that. But actually, when you look at it, it's not like that at all. But we've labelled things to allow us to basically be examined on it and tested on it. But actually, reality isn't there. And all you're doing is going back to the anatomy and saying, well, hang on, how is this supposed to work? But 20 years ago, I mean, obviously, our careers have changed and that sort of thing. But 20 years ago, I feel like every meniscal injury was the same. Every ATFL was the same. But it seems like by going back to, well, hang on, not every injury is the same. They're all slightly different. But going back to the anatomy has allowed us to maybe re-look at some of these injuries.
But I think we've also looked at now at the biology. So we didn't used to have the robotics where we can actually look at things very carefully, which we're doing at Imperial, which is amazing. So we can actually see what's happening in real life, or recreating those injuries and those movements that we have in real life, which we couldn't ever do. We could look at it very clunky beforehand. We've now got the surgical techniques, which we never had 10 years ago, to be able to do anatomical repairs and actually looking at specific ligaments rather than looking at a big piece of tissue and pulling it back up again. And augmenting it with certain implants, which, like a fibre tape occasionally.
Which has got much better in terms of replicating the sort of viscoelastic properties of tissues and that sort of thing. Last question, James. Are you going to ever be replaced by a robot?
I hope not. Probably not in my time. I think there's a lot more that we can do with robots. I mean, there's amazing robotic lab up in Cambridge, CSM Robotics, I think it is, but they're doing soft tissue robotics. And Mark Slackett there, and
that's literally you put it into a computer, how to do it, and it does it.
Yeah, and you've got to have a person. At the moment, they're sort of sitting in the room next door, and they're doing gallbladders and things like this. But they could be sitting in, I don't know, wherever, the South Pole, wherever.
Could be in the south of France.
I don't know whether it's going to completely replace the surgeon. Would I at the moment feel nervous? I'd feel nervous having my car drive itself and it's going to go.
Let alone have your ligament repaired.
The latest report from Tesla earlier, or the whistleblower from Tesla this week, probably wasn't terribly encouraging about some of the problems that could ensue there. It'll come, and I think they can be computer aided. And certainly,
which you're doing already here with robots for knee replacements.
Knee replacements here are done, and I definitely want, if I have to have a knee replacement, I'll have a robot assisting it to make sure it's in
just to be clear, it is just assisting, isn't it? It's not actually taking over the whole thing.
No. So I think it's like, could the robot give my anaesthetic? I wouldn't be too keen on.
It's always nice for somebody just to hold your hand and the softer touch is quite nice. Well, hopefully your job is secure for a few more years, James. So thank you very much for joining us. That was a very interesting conversation.
Not at all. Really, really good to speak.